This is the first lecture in the series on the cardiovascular system. In this lecture, I need to go over an introduction to the CVS and general anatomy, although we will not be doing heart anatomy in this lecture. Also need to cover hemodynamics and measurements of cardiovascular function. The reason we have cardiovascular system is because diffusion has limits. All our cells use oxidative metabolism, they use mitochondria to produce ATP, so they need to have a steady supply of oxygen and nutrients to allow them to do this. If oxygen diffusion alone was used, it would take approximately 15 milliseconds for oxygen to diffuse into the middle of the cell, and would take approximately 1 year for oxygen to diffuse into the middle of the body. The solution to this is to create an oxygen transport system, which allows oxygen to travel from the air into the blood by diffusion, and for the blood to pass from our lungs to our tissues by circulation. This is a convective process which requires a pump. The pump in question here is obviously the heart, and the heart itself requires metabolic energy in order to do its job. We then need to think about how oxygen gets from the blood into the tissues when it's in the capillary beds, and again that's by diffusion. I want to work through this diagram with you slowly. So if you follow where the numbers are, number 1 is the right atrium. You can find this figure in your Tortora textbooks. So blood enters the heart at the right atrium. It's deoxygenated blood at this point, passes through one of the valves into the right ventricle. The valve in question is the tricuspid valve. Once in the right ventricle, as the heart contracts, it forces blood from the right side of the heart through the pulmonary valve and into the pulmonary trunk and the pulmonary arteries. These are unusual in that they carry deoxygenated blood, whereas other arteries in the body carry oxygenated. The blood passes through the pulmonary arteries into the pulmonary capillaries of the lungs. At this point, blood loses CO2 and gains oxygen by diffusion. The oxygenated blood then passes from the lungs back to the heart through the pulmonary vein. The oxygenated blood passes from the pulmonary vein into the left atrium, and then via the bicuspid valve into the left ventricle. From here, as the heart contracts, blood is forced from the left ventricle into the aorta through the aortic valve. The aorta and systemic arteries then pass the blood around the rest of the body. Once in the tissues, the blood passes through arterioles and into the capillary beds. These are the systemic capillaries. The blood loses oxygen and gains CO2. Blood is then drained back into the heart via the 3 major veins of the coronary sinus, inferior vena cava and the superior vena cava. What you need to learn from this slide is the direction of the blood flow, where oxygenated and deoxygenated blood either arrives or leaves the heart, and you need to be aware of the blood vessels involved. For the tricuspid and bicuspid valves, it's enough to know them as the atrioventricular valves. The oxygen, as it passes from the air into our lungs, and then from lungs into the blood and the tissues, passes down its own concentration gradient. In this case, we measure it as pressure of oxygen, so partial pressure of oxygen, PO2, in millimetres of mercury. If you have a look, first of all, the first line on the graph, you see at the air, partial pressure of oxygen is around about 150 millimetres of mercury. Once the air is inside the lungs, due to the changing environment, partial pressure of oxygen drops dramatically. That allows oxygen then to pass from the air and diffuse through the lungs and into our blood. Once the oxygen is in the blood, the next big drop in the partial pressure is between blood and tissues. This is because the tissues are metabolically active, so the concentration of oxygen around the cells is going to be significantly lower than the concentration in the blood. Therefore, the oxygen diffuses out of the blood and into the tissues. Once it's in the tissues, it's used for mitochondria in oxidative metabolism. We've mentioned about the cardiovascular system briefly. The cardiovascular system in total has all the blood circulation in your body, your heart and your lungs. It's essential for the delivery to the tissues to get nutrients to them, such as oxygen, glucose, amino acids, fatty acids and water, and for the removal of toxic metabolites such as carbon dioxide, urea and creatinine. It's also essential for circulation of hormones to allow our endocrine functions and for temperature regulation. If you think what happens to you when you get very hot, you become very red, and that's because you've got vasodilation of the capillary beds of your skin. That brings the blood closer to the skin. That allows heat to radiate out of your skin. It means you go very red because the blood is closer to the surface, but allows your temperature to come down. Your core temperature must remain around about 36.5 degrees Celsius. Your peripheral temperature, so your fingers, and your toes and your feet, will always be several degrees lower than your core temperature. When we discuss about cardiac output, we're referring to the amount of blood that's been coming out of the heart per heartbeat. So cardiac output in percentage of that, and oxygen consumption as a percentage of the total oxygen in the blood, varies between the organs. If you have a look at some key organs on this table, this shows the key organs that we need to know about. So for the brain, approximately 13% of the cardiac output goes to the brain, and the brain uses approximately 18% of the oxygen in that output. The heart itself has a much smaller proportion of the cardiac output. Only 4% of the blood that exits the heart actually goes to the heart itself. Conversely, skeletal muscle, 20% of the cardiac output goes to skeletal muscle. It's a very large body of muscle if you think of all your skeletal muscle in your body, and it requires approximately 20% of the oxygen that's available in the blood. Skin, as you would imagine, has a low cardiac output percentage, and again a low percentage of the oxygen consumption. The one I need to draw your attention to here are the kidneys. 20% of the cardiac output goes to your kidneys, and they only use 6% of the oxygen. I want you to think between now and the next session why you think the kidneys have such a high cardiac output. If you compare your kidneys to the amount of skeletal muscle you have in your body, they are significantly smaller than the mass of skeletal muscle, and yet they have the same amount of cardiac output. So I'd like you just to think why that may be. I want to discuss a little bit about how the blood flows around the circulation. We've mentioned already that oxygen passes down a concentration gradient when it goes from the air to your lungs, the blood, and then your tissues. The same is true for blood flow, except in this case it's not a concentration gradient but a pressure gradient. If you have a look at this diagram, again you can find this in the textbooks, but it's here so you don't have to. The first part of the diagram shows a schematic of the blood circulation in your body, going from arteries to arterioles, tissue capillaries, and then the venules and up to the veins. The highlighted section in the middle shows the capillaries themselves and what's actually going on in that particular part of the blood circulation. If you look to the blood pressure line, you'll see that it's a pulsatile pressure. You have increases and decreases regularly. As the blood moves from the arteries to the arterioles, you see a dramatic drop in blood pressure. Once into the capillaries, the blood pressure tails off again, doesn't increase, and then it stays low throughout the venules and the veins. The reason for that is because as your heart is beating, that increase in force increases your blood pressure. As the heart relaxes, that pressure drops again. As you're getting into the arterioles, you're moving further away from the heart, so the pressure of that heartbeat is less, and you need to have a low blood pressure in the capillaries, otherwise you'd damage the capillary bed themselves. The second line on the graph shows blood velocity. Again, it's pulsatile, as you would expect with the heartbeat. In this case, although the velocity does slow down between arteries and arterioles, it isn't as significant or greater drop as that for blood pressure. Once you get into the capillaries, however, the blood velocity dramatically slows down. It actually increases slightly at the venous end of the capillary bed as it heads into the venules, the veins, and back up to the heart. That's to maximise the amount of contact time the blood has with the cells of the capillaries. That will maximise the amount of oxygen that can diffuse out and the amount of waste products and CO2 that can diffuse into the blood. The final line on the graph shows the total cross-sectional area for the blood vessels by type. The main thing I need you to take from this is that the capillaries have a massive total cross-sectional area compared to any of the other blood vessels. Again, that maximises the amount of diffusion that can occur as you are maximising the contact space. You need to know the information on this slide. This shows the five major blood vessels that you need to know about and their main characteristics. So first of all, the arteries. These are large blood vessels that generally carry oxygenated blood. The one that doesn't with that is the pulmonary artery. That is the exception. Arteries are surrounded by smooth muscle. This enables contraction and relaxation, which allows us to regulate the blood pressure. They're controlled by the autonomic nervous system and have a considerable elastic material component. The arterioles are small branches from the arteries which connect the major arteries to the capillary beds. Again, they're surrounded by the smooth muscle and they're known as resistance vessels. If you remember from physics, resistance is proportional to 1 over radius to the power 4. In other words, it's inversely proportional to the radius. The wider the vessel, so the larger the radius, the lower the resistance, and the same applies in the converse as well. This allows us to control blood flow through the arterioles. That allows us to control blood pressure, but also to control the speed of blood flow through the capillary beds. Vasodilation is the situation where the blood vessels become wider. Vasoconstriction is a situation where the blood vessel becomes narrower. Once through the arterioles and into the capillary beds are only 1 cell thick. That allows a maximum exchange of nutrients and oxygen. Remember that diffusion is a very slow process. It takes a very long time to occur. If you had thicker walls for the capillaries, the oxygen would not be able to diffuse out. Finally, to the venules, these connect the capillaries to the veins, and the veins themselves collect the blood and carry the blood back to the heart. Neither the venules nor the veins have a significant amount of smooth muscle. They are mostly connective tissue, and the veins contain valves as you go up their length. That is to prevent the backflow of blood, but we'll come to that more when we do the heart. For the changing composition of the blood vessel walls, this table shows the percentage composition of the walls of each of these 4 blood vessels by type. You do not need to know all the numbers, but it is useful to remember the major component of each of the types of vessel. So for the elastic artery, very small amount is endothelium, approximately 25% smooth muscle, but 40% elastic tissue. So in the case of the elastic artery, the elastic tissue is the predominating composition. The arterioles, resistance vessels, 60% of their wall is composed of smooth muscle. Only 10% is endothelium or elastic tissue, and the remaining 20% is connective tissue. The capillaries, which are also sometimes known as exchange vessels, 95% of their cellular wall composition is endothelium. There's a small amount of connective tissue, only 5%, which allows to hold the cells together. There is no smooth muscle or elastic tissue in the capillaries. Finally, the venules, and this applies to the veins as well. Again, there's no elastic tissue, approximately 20% endothelium, 20% smooth muscle, but 60% connective tissue. So the veins and the venules are not capable of vasoconstriction or dilation. They do not stretch, however, they are involved in carrying the blood back to the heart. After discussing the way the blood flows around our body, it's sensible to come back up to the heart and discuss some of the terms that we use when we refer to cardiac output. Cardiac output is defined as the volume of blood ejected by one ventricle of the heart in 1 minute. Stroke volume is the volume of blood ejected from the ventricle in one contraction, so 1 heartbeat. If we take Mr. Average as being a 70 kilogram man with a heart rate of 70 beats per minute and a stroke volume of 70 millilitres, so 70 millilitres of blood has been ejected from the ventricle in one contraction. If we put that into the equation, cardiac output equals heart rate times stroke volume. In other words, how much blood is being ejected in 1 beat, multiplied by how many beats per minute. That gives us a value, in this case, of 70 beats per minute multiplied by 70 millilitres equals 4,900 millilitres per minute, so around about 5 litres. That's a considerable volume that's passing through your heart in any one day. The old rule of thumb used to be for every stone in weight you were, you had 1 litre of blood. So if you are a 10 stone adult, you will have probably 10 litres of blood. That gives you an idea of the sheer amount of blood that's passing through your heart in any one day. Remember, the heart is a pump. It's the best pump known to man. It never tires. It contracts, and as it contracts, it expels blood. That causes an increase when you look at pressure over time. It's a pulse style graph, which means that the pressure increases and then decreases. The pressure increase is due to the contraction. We also call this systole or the systolic blood pressure. The drop in pressure over time is when the heart relaxes, it stops beating, blood then fills up the atria and the ventricles, and we call this the diastolic period or diastole, and this pressure is the diastolic blood pressure. When you go and have your blood pressure measured, you are given two values. This is always assuming that atmospheric pressure is taken to be 0 millimeters of mercury. That does change slightly whether you have your blood pressure measured at ground level or up a mountain. Have a think about how it might change. Your maximum arterial blood pressure occurs during ejection of the blood from the heart into the arteries, so the point of systole. If you have your blood pressure measured, you are given two values. The values we've used here are 120 millimeters of mercury over 80 millimeters of mercury. The 120 relates to the maximum arterial blood pressure at the point when the heart is in systole and is contracting. The minimum arterial blood pressure is referring to when the heart is in diastole, it's relaxed, it's not contracting, and it's filling with blood. You'll be given that value by the doctor as a 120 over 80 millimeters of mercury to indicate what your pressure is at the maximum heart contraction versus minimal heart contraction, so maximum relaxation. In the lungs, these values are significantly smaller, so 25 millimeters of mercury over 10 millimeters of mercury. That's partially due to the fact that you're further away from the heart, but also due to the size of the blood vessels. Remember that graph where we showed that velocity and blood pressure drop dramatically in the capillaries? In the lungs, the values we're looking at tend to be the values of your blood pressure in capillary beds. When you look at the systolic and diastolic blood pressures properly, instead of being a smooth curve and a sine wave, we actually have a slight blip. So from your diastolic blood pressure, heart starts to contract, that gives us a systolic pressure, so the upshoot of the graph. The heart then starts to relax, so the blood pressure drops, but then we have a slight jump in blood pressure as it gradually comes back down again. The value we are interested in when we're looking at blood pressure is pulse pressure. So the difference in your blood pressure between that of systolic minus diastolic. In the examples we've given, this would be 120 minus 80. So the pulse pressure for this individual is 40 millimeters of mercury. What we're actually interested when we look at people's blood pressure, although it's very useful to have diastolic and systolic pressures, we actually want to know what the mean arterial pressure is over the entire cardiac cycle. So that's the mean arterial pressure, or MAP, being the mean pressure over the cardiac cycle. We can calculate that by taking our diastolic blood pressure plus the pulse pressure divided by 3. In this example, if we put the figures in, the MAP equals 80 plus 120 minus 80 divided by 3, which gives us a mean arterial pressure of approximately 93 millimeters of mercury. Those of you who are mathematically minded may think that it should be pulse pressure divided by 2 in this equation. That would be the case if it was a straightforward sine wave and the pressure increased and then decreased at the same rate. It does not in the heart, except at very high heart rate, because we have a rapid increase followed by a blip and a much slower decrease. That then changes the shape of the pressure versus time curve, which means that we have to divide pulse pressure by 3. You don't need to worry about the physics, flow dynamics, or the maths behind that, but you do need to remember that mean arterial pressure is diastolic pressure plus pulse pressure divided by 3. If we put that in a diagrammatic form, so we have an artery going into the tissue and then a vein coming out, what we're interested in is the amount of pressure that's forcing the blood from the artery through that tissue and out to the vein. That's a quite simple value to work out if we know our arterial pressure and the venous pressure. In this example, arterial pressure is PA and the venous pressure is PV. So the pressure driving blood through the tissue is the difference between these two values, or delta P. If you remember, those of you who did physics, we have Ohm's law of voltage equals current times resistance. In this case, we're looking at the flow of liquid, so blood, through vessels and tissues, rather than looking at how much electrical current is being conducted. If we look at this at fluid flow and we change those values, the voltage becomes delta P, so the pressure driving the blood through the tissue. The current becomes blood flow and the resistance is still resistance. So we can rearrange that equation to give flow as being the volume of blood passing through the tissue in 1 minute is equal to the difference between arterial pressure and venous pressure divided by a resistance. Now imagine applying this to all the tissues in the whole body rather than an isolated organ. The equation stays the same, so flow equals delta P over resistance. The total blood flow through all the tissues has got to be the same as the cardiac output, so the volume of blood pumped out by the heart. It can't be greater than that. In which case, delta P, so the difference between your arterial and venous pressure, is equal to the mean arterial pressure minus the central venous pressure. In this case, we can assume that the pressure in the veins, so the central venous pressure, is significantly lower than the mean arterial pressure and possibly verging on naught, in which case, when you put that value into the equation, it becomes the delta P is approximately equal to the mean arterial pressure. In that case, if R is total peripheral resistance, its TPR sometimes is called systemic vascular resistance. If you put that into the equation, our cardiac output must equal mean arterial pressure divided by the total peripheral resistance. Usually that's not what we want to find out. We usually want to work out what the mean arterial pressure is, so we just rearrange that equation to become mean arterial pressure is equal to cardiac output multiplied by the total peripheral resistance. You must know that equation. You don't need to worry too much about how we get to that equation. It is useful if you can remember it, but you must know that final equation. So why is this important? The reason the mean arterial pressure is important to know is because it's controlled by the cardiac output and total peripheral resistance, both of which may be altered in cardiac disease. So you may have a situation where you have dramatic increase in peripheral resistance due to some kind of occlusion in the blood vessel. This allows us to have two therapeutic strategies to control the blood pressure. So if we wanted to decrease blood pressure in a patient whose blood pressure had gone too high, we could either decrease their cardiac output or decrease the peripheral resistance. Either of these strategies would work to reduce their blood pressure. If we wanted to alter cardiac output, we could alter the force of contraction of the heart, and we could alter the volume of blood ejected. Alternatively, we could reduce the frequency, so alter the frequency in beats per minute. Alternatively, we could alter the resistance. Remember that resistance is inverse to the radius. So if the muscular walls of the arterioles, allowing their diameter and consequently resistance to be changed through vasodilation and vasoconstriction, this allows us to target these vessels to either increase or decrease blood pressure as we need to by altering the resistance. This is why we refer to arterioles as resistance vessels, and these are the main regulators of blood flow. When we're doing all these measurements of cardiac function and cardiovascular function, we generally want to stick to non-invasive mechanisms. So for normal measurements of CVS function, we could use pulse rate, so palpation of the wrist, pulse rate meters. You can measure this on yourself by taking your two finger digits on one hand and resting them on your wrist just down from your thumb. If you apply slight pressure there, you will feel your pulse rate coming through. You don't use your thumb to measure pulse rate because your thumb has its own pulse, so you'd only actually measure your own pulse there. Alternatively, you could listen to heart sounds. This process is called auscultation, and is the procedure where a medic will use a stethoscope to listen to the sounds your heart is making. They're waiting to hear clear-cut sounds so they can hear the contraction of the atria and then the contraction of the ventricles separately. If there's any sort of hissing or mixing of the two sounds, it suggests that there's a problem. We can look at the arterial blood pressure using a sphygmomanometer. This is an indirect but accurate measurement of blood pressure, and it can be done either manually or via an automated machine. We can also look at the heart function using an electrocardiogram, which actually shows us how the electrical wave propagates through the heart, or by doing an echocardiogram. In the echocardiogram, that allows us to visualise what is actually happening to the flow of the heart and to see how well the valves and the actual heart itself is functioning. Finally, we can also look at peripheral blood flow using a Doppler ultrasound. This is very similar to what is done during a pregnancy ultrasound. In this case, it's used to measure the blood flow. So, for example, if you're identifying peripheral blood flow through, say, the femoral vein, if you're looking for blood clots, you'd use a Doppler to have a look and see how the blood is flowing through that particular vessel. In more severe cases, so issues where we have maybe heart failure or transplant patients, we may need to get far more detailed readings, in which case we have to go to invasive tests. These are always done either in hospital or at least as an outpatient, mainly because the risk of infection is significant. So the first things we could do is arterial catheterization. This is where a catheter is inserted into one of the arteries directly, and it gives us a direct and continuous measure for the blood pressure in that particular artery. That can be left in place so you can get a feel for how the blood pressure maybe changes if there's an irregular heartbeat, for example. Alternatively, you could undergo a full cardiac catheterization when the catheter is inserted directly into the blood vessels and into the heart itself. This allows us to measure the pressures within the ventricles and the atria, as well as the blood vessels coming to and going from the heart. It will allow us to directly measure the ECG in the heart itself. It also gives us the potential to measure cardiac output by indicator dilution. So an indicator will be added through the catheter, and we then see how long it takes for that indicator to be diluted to a certain amount, and from that we can work out the actual volume of blood being ejected from the heart. Finally, you could also use the catheter to introduce a contrast media, which will then allow you to x-ray the heart and see what is going on. Obviously, normally an x-ray won't show you much with the heart. In summary, for this first section then on the CV system, you need to be aware of what we've covered in terms of the general anatomy, so which way the blood flows, which vessels contain oxygenated, deoxygenated blood. You also need to be aware of the composition of the major blood vessels and the physics principles relating to pressure, flow and resistance. Finally, you also need to understand about the measurements of cardiovascular function. If you need any help, please do not hesitate to contact me. I've now moved downstairs, so my office is 0.54 on the ground floor of the Hornbeam building. Alternatively, you can email me at my usual email address and I'll do my best to help.